Hello, today I'm going to speak about symptoms that patients with acoustic neuromas can have, but specifically I'm going to talk about the less common symptoms and discuss the causes of these symptoms and how patients with these less common symptoms can manage and treat them. So in terms of common acoustic neuroma symptoms, we're all aware that hearing loss and tinnitus are perhaps the two most common causes of these types of tumors. These compromise perhaps 80 to 90% of the presenting symptoms for patients with acoustic neuromas. In addition, we are well aware that balance problems can occur with acoustic neuromas, which in fact are tumors that grow off of the balance nerve rather than the hearing nerve. And finally, vertigo or dizziness is a common acoustic neuroma symptom. So what are the atypical or less common acoustic neuroma symptoms? I'm going to, for the purposes of this webinar, classify uncommon acoustic neuroma symptoms as those symptoms that occur in less than 5% of patients with acoustic neuromas. And these are also symptoms that, at least on the surface, may not appear to involve the inner ear, which can be confusing for patients. And these can also be symptoms that, at least initially when they start occurring, do not make intuitive sense to the patient, meaning it's difficult for the patient to connect the symptoms to their acoustic neuroma. So let's see what some of these uncommon symptoms are. The first type of less common symptom for patients with acoustic neuromas is actually the presentation of face pain. So this is typically sharp electrical shocks into the cheek or jaw, or less commonly the forehead. And they occur on the side of the face that the acoustic neuroma is located on. And these symptoms are related to pressure on the fifth nerve or the trigeminal nerve. We know that the acoustic neuroma comes off of the eighth nerve, and we know that the facial nerve, which controls movement of the face, is the seventh nerve that runs very close to the tumor. But when we're talking about face pain, we're actually talking about the fifth cranial nerve, and this is the trigeminal nerve. So in this, this is one of my patients here who has a relatively small acoustic neuroma shown in white here, but he had also presented with pretty severe face pain on the right side. This tumor is located on the right side of the patient. So when we look at the contrast MRI scan, which is this one here, we can clearly see the tumor shown in white with the contrast dye, but we can't really appreciate why the patient is having face pain. However, on a different sequence, this is a called a Fiesta MRI sequence. It's the same patient. We can see the tumor as this grayish round mass here. This is a non-contrast sequence, so the tumor is not lighting up with contrast dye, but we can see it right here. And there is a view of the trigeminal nerve, the fifth nerve, coming off of the brainstem here, running forward to the face. And we can see the edge of the tumor is pushing on this nerve. So this is a symptom of direct pressure of the tumor on the actual nerve. So if you have an acoustic neuroma, how do you manage it if it is causing face pain, if you're in one of these 5% of patients that have face pain? And I think one of the big questions I ask patients who present with this type of symptom is, can you live with the pain if it never got better? So essentially, it's trying to ask the patient how bad the pain is and how important is it for the pain to be completely eliminated. If the pain is mild and the patient says that they can manage the pain without a lot of difficulty, then the patient can be treated with radiation, stereotactic radiosurgery, and you can supplement with a specific type of nerve stabilizing medication such as Tegretol, which is also generically called carbamazepine, or gabapentin. And these are medications that settle down the nerve and are less likely to have the nerve fire off and cause pain. If the patient tells me that they cannot live with the pain, that it's critically important to eliminate the pain, then the only real treatment recommendation would be surgical resection. And the reason for this is that it is important to get the pressure off of this fifth nerve, the trigeminal nerve. And by removing the pressure on the nerve, the face pain goes away in the vast majority of patients, approximately 95% of patients. Another type of less common symptom is actually facial twitching or muscle spasms in the face. This is actually very rare. It occurs in 1% or less of patients with acoustic neuromas. And this involves irritation of the facial nerve, which is the 7th cranial nerve. This nerve runs parallel to and right next to the 8th cranial nerve, which is the nerve that the acoustic neuromas grow off of. The facial nerve is typically a very strong nerve, and it can tolerate a lot of irritation and pressure, which is why this symptom is not common. However, in certain circumstances, the nerve becomes irritated enough that it fires off, and this causes the twitching in the patient's face. The treatment in a patient with facial twitching, if you choose to treat the acoustic neuroma, the radiosurgery versus surgery, there's some controversy here because we know clearly that surgical resection of the tumor, getting pressure off the facial nerve, has a good chance of eliminating the facial twitching. But it also turns out that radiosurgery, of stereotactic radiosurgery, when you treat the tumor, also in the long run has a pretty good chance of settling down the facial nerve and stopping the twitching. So this third possible unusual symptom is actually facial weakness. So we saw in the last slide how some patients have facial twitching. That is the facial nerve and the muscles of the face being overly excited, being irritated to the point that they are overly active. Facial weakness is the opposite problem. It is a situation that occurs, again, in 1% or less of patients with acoustic neuromas. But in this situation, the facial nerve is actually weaker than normal. It is injured and it's no longer overly active, it's underactive. And this can occur if the nerve is stretched, and this causes dysfunction in the nerve and lack of normal electrical signal conduction in the nerve. And this causes the muscles of the face to be weak. So if we see this type of situation, it tells me that the nerve is under a lot of pressure and not really happy about the situation. And the optimal treatment for these patients generally favors surgery, because the goal is, by removing the tumor, you can take the pressure off of the nerve, and hopefully that will improve the nerve's function. And in some patients, but not all, the facial weakness can improve it if the actual tumor pressure was the cause. You can do stereotactic radiosurgery in certain acoustic neuroma patients who present with facial weakness, but the downside of radiosurgery in these particular patients is that the radiation often just kills the tumor at the current size. So we call this tumor control, and therefore the tumor, even though it may no longer be alive, may still be putting pressure on the facial nerve, and this can cause the facial nerve to continue to be stretched and weak, and this can continue to cause the facial weakness. Another unusual symptom is actually weakness in the arms and legs, and this is very uncommon because we only see this with very large tumors. So here is a picture of a large acoustic neuroma. This would be about a 4 to 5 centimeter acoustic neuroma, and it is putting significant pressure on the brainstem, which is this gray structure here, which extends down into the spinal cord, which starts right here. So when you have an extremely large tumor, it compresses the nerve fibers that start from the brain that come down through the brainstem to the spinal cord, to the arms and legs. And in situations where the tumor is large enough, this compression causes these nerve fibers that are going to the arms and legs to become dysfunctional, and then that can cause weakness. So this is a pretty extreme situation. It's almost always treated with surgical resection. Radiosurgery is not used in this situation because these tumors are in fact typically too large to undergo radiation, and so surgery is really the only treatment option for these patients. And by removing the tumor, you are essentially taking the pressure off the brain and the spinal cord, and taking the pressure off of these nerve fibers that connect the brain to the arms and legs. And this generally results in significant improvement and or resolution in the weakness of the arms or legs. The next type of problem that we can sometimes see, though rarely, are actual swallowing problems. This involves compression or stretching of what we call the lower cranial nerves. So the nerves that are involved with swallowing function are nerve number 9 and nerve number 10. And I'll show you a picture of how close these nerves can lie next to the actual acoustic neuroma tumors. Now, these nerves control the muscles of the throat and are the nerves involved with the swallowing function. And because they go to muscles, they're considered motor nerves. Motor nerves are those nerves that supply muscles, and they're typically very strong. So that's why this is a very unusual presenting symptom, because these nerves can tolerate a lot of pressure by acoustic neuroma tumors. They can tolerate stretching to some degree, and it requires usually a pretty large tumor or pretty significant compression or stretching of these nerves number 9 and 10 to cause dysfunction that would cause swallowing problems. So if we see significant swallowing problems, again, the treatment options, surgery versus radiation, need to be weighed here. Surgery allows immediate decompression of these nerves that control swallowing, while radiation oftentimes doesn't result in a rapid decompression of these nerves, because the tumor typically dies at the size it was on the date of treatment and doesn't involve a lot of shrinkage. And if there's not shrinkage of your acoustic neuroma tumor, it may not take pressure off of these nerves. I want to show you a picture of how these nerves are located. So in this particular picture here, we see the acoustic neuroma tumor here. These white structures on either side of the lower part of the nerve are the 7th and 8th nerve, the facial nerve and the balance and hearing nerves. And the 8th nerve is the nerve in which the tumor arises from. But you'll see a number of these off-white lines running here. And these are the 9th and 10th cranial nerves. So these are the nerves that control swallowing function. So you can see how close they are located to this relatively small acoustic neuroma. And you can imagine that if this tumor were larger, it would be growing in this direction, among other things, and that could be compressing these nerves that are involved with swallowing function. Another very unusual symptom is actual double vision, and this is extremely rare. We almost never see it in acoustic neuroma patients, and this typically involves compression or stretching of the 6th cranial nerve, and this is one of 3 nerves that controls eye movement. And if this nerve is compressed or stretched by an acoustic neuroma, it can result in your 2 eyes not moving together, so they do not track together. So because the eyes do not move together, you actually see 2 images, and hence the double vision. The 6th nerve is a motor nerve. It goes to the muscles of the eye, and again, motor nerves are very strong. The 6th nerve is very long and mobile and can move much more readily than the other nerves that I've talked about in this presentation. But occasionally it can be stretched to the point of dysfunction, and this can cause double vision. And if this is the situation, usually surgery is recommended because it's very unlikely that with radiosurgery you would have resolution of the double vision. The next symptom that we see from time to time in patients, occurring about 2 to 4% of patients with acoustic neuromas, is hydrocephalus. And hydrocephalus is a term that means buildup of fluid on your brain. The fluid is called CSF, or cerebral spinal fluid. It is the fluid that your brain and spinal cord float around in, and it's a normal fluid that is present in all patients. Approximately 150 cubic centimeters or milliliters of this fluid is present in your body, and that's about 2/3 to 3/4 of a typical soda pop can worth of fluid. Now, the fluid is produced in the center of the brain and floats out to the outer surface of the brain and spinal cord, where it is then reabsorbed by the body. So this cerebral spinal fluid is produced and absorbed by the human brain, and it creates kind of a filter system. Now, when you have an acoustic neuroma, sometimes the tumor can secrete protein into the spinal fluid, or it could directly compress some of the fluid pathways. And in either situation, what this causes is an imbalance between fluid production and fluid absorption. In this case, your body produces more fluid than it can absorb, and this results in the diagnosis of hydrocephalus. So what are the main causes of hydrocephalus? The three main causes we typically see are ataxia, which is balance problems when you walk, urinary incontinence, and memory issues. Generally, these symptoms are gradual in onset, occur over months, and the patients initially may have a hard time connecting this to a tumor on the hearing nerve. So the treatment for hydrocephalus, you can, depending on the size of the tumor and other symptoms, do either surgery or radiosurgery, but in many cases you have to directly treat the hydrocephalus itself, and I'll explain how that is done. So this is a picture of two brains. The brain on the right side shows the normal sized ventricles. The ventricles are these black structures, fluid-filled spaces of the brain, and this is a patient with hydrocephalus, so you can see how much larger these structures have become. In addition to actual treating of the acoustic neuroma, sometimes we have to place a shunt, which is a small surgical tube, into the fluid-filled spaces of the brain to drain the fluid. And the shunt is an internal system. It drains the fluid within the patient's body and helps the body reabsorb the fluid. I want to talk a little bit about a couple other topics before we end this webinar. The first is to talk about whether you should do early radiosurgery versus waiting for radiosurgery on tumors. And this is a question that comes up quite frequently. I think the best paper that answered this question came from the group at the University of Pittsburgh, where they looked at patients that underwent radiosurgery within 2 years of diagnosis and compared them to patients that underwent radiation more than 2 years from diagnosis. And essentially what they discovered was that patients that underwent radiation fairly early after diagnosis of their acoustic neuroma maintained hearing at a greater rate than patients that underwent radiation more than 2 years from diagnosis. So it appeared that intervening early, if you're going to choose radiation for your tumor, gives you a better chance of hearing preservation. They also showed that actual tumor control rates, the likelihood of killing the tumor, was better in the group that had higher hearing, that had earlier treatment rather than later treatment. This is just the slide from their paper that showed that the percentage of patients retaining hearing is this black line here. So there was some decline over time, but if you had early radiation for your tumor, you had a better chance of maintaining hearing than patients with late radiation for their tumor. And this is the last slide I want to talk about. This is from the same paper showing that patients that had hearing classified as 1 or 2. So this is actually patients with very good hearing, again, did better with early radiation treatment than with last treatment. So that's what I wanted to present today. I hope that you have found this webinar information helpful in terms of understanding the less common symptoms of acoustic neuroma presentation. Thank you.